shot option from Sayama we went.
Good evening, teacher and everyone here. I am thrilled to welcome you all for today's informative webinar on exploring the reversibles, type 2 DM management and goals. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Navonil Dutta. Dr. Navonil completed his MBBS and earned his fellowship in cardiology from Mediversal Academy, an award-winning clinician. He secured best case presentation at Consensus 2019 at JIPMER, Puducherry, reflecting strong clinical reasoning and academic excellence. He trained in pulmonary medicine at AIG Hospital, Hyderabad, and served relentlessly, sorry, relentlessly as frontline physician during COVID-19 from 2020 to 2022. Continuing his duties despite personal illness are testament to his resilience and professional integrity. Deeply committed to lifelong learning and mentorship, he takes holistic interest in cognitive neurosciences, behavioral sciences, and interconventional psychiatry. Over to you, doctor.
Thank you. Thank you so much, Vijay. Good evening to everyone. I hope you're doing well. And as the season tends to shift now from the last few months of relentless winters to, a bit more warmer, sunnier days, I hope so does life happen to you. I hope life happens to you in the best of ways. Uh, Gives you good reasons to wake up every morning, gives good reasons to go to bed every night. And I hope that you all are doing hail hearty and everyone in your family is doing well. So, as I can see, there are almost 65 of you, 69 almost, who has joined. I'm so glad. Good evening to all of you. Today's topic, it's a crisp one. Trust me, unlike any of my webinars till now, it's going to be a very, very short session because I'll be predominantly talking about guidelines. I'll be predominantly talking of what has been said already. And there's a little surprise for all of you in the end. That is, I have updated my slide today morning with the current NICE guidelines that have been set up, the NIC guidelines that have been set up very recently. I mean, till today for diabetes management, we were using the NIC guidelines of 2022. That was the latest guidelines that we had. But now NIC has come up with its recommendations for the 2025-26 session, and we have some changes. We have some notable changes in the way that we would treat diabetes as a clinician. However, uh, treatment of diabetes is not my topic of discussion for the day. The most important part of today is not type 2 diabetes mellitus. It is about exploring the reversibles. If you have been a part of my series of webinars that I have been conducting since quite a long time now, it's been almost more than a year that I've been taking webinars for Mediversal. You must have encountered a webinar where I clearly talked about type 1 diabetes, type 2 diabetes, its medical goals, its management. I have talked about in detail, in extensive detail, about insulin preparations, about the oral hypoglycemic drugs that we have, the mechanism of actions, their side effects. So we have done we are done with those topics for sure. So the one thing that is left to be explored is the reversible things in type 2 diabetes, like weight. Weight is one thing that we can reverse. Weight, lifestyle, these are things which can be reversed back to what a patient happened to be in their pre-diabetic or before they became diabetic, that stage, to be honest. So it's about exploring the reversible risk factors, or let's say the modifiable risk factors for diabetes. And as an adjunct, just because NICE has come up with its latest guidelines, and webinars are the best place that I feel that we can talk of the recent updates of medicine. I wanted to put up the recent NICE guidelines in the end. So before I begin, just as as an anecdote of anything that I would want to say ahead. I would first want to connect to all of you. I would want to know uh, what are the other topics that you would be wanting me to do at some point of time. Maybe I'll just take this liberty today because usually मेरे webinars बहुत लंबे होते हैं and I do not have that space to include in stuff. But I hope people who have joined in today are people who have been with me for a very long time, who have been, you know, watching me, observing me, hearing me for a very long time, and I'm extremely grateful to all of you. So, you know, I would just want to know what are the topics that you would want me to take up in the further webinar sessions. So maybe just 2 to 3 minutes of that, and then we'll be going on with this. Thank you so much. I'm not able to read out your names, but I can definitely read your texts out. Neuro emergencies management. Okay. That's one thing which I'll be writing it down. So just give me a moment. I'll be writing these down, and trust me, each of your suggestions will matter. So I will be writing down neuro emergencies. Okay. What else? Anything else? I've already taken a webinar on chest pain. I have taken on neurocognitive disorders. Thank you so much. Thank you. See, each of these texts means a lot. Okay, hypertension new guidelines. Yes, that is extremely important. Hypertension new guidelines. Okay. I'm writing this down again. Sutures. Okay. See, I'm not a surgeon. I think sutures is something that Alan Sir will take up better. So he will probably management of diabetes and insulin doses. My doses. I think, dear, I've covered this in one of my earlier webinars. Doctor, I'm not able to read your name out. Asya, if I'm not very wrong. This is covered in one of my earlier webinars. This is basically the second part of that diabetes webinar which I was supposed to take. So this is where we will be talking more about the modifiable risk factors. I have covered about the insulin medications and that I mean the other diabetes medications in my previous webinar. Echo. Okay, I can consider that. Type 1 DM has been talked of. Okay, emergencies and their management. Syncope. Okay, approach to syncope. Yes, this is something really nice. Approach to syncope can be talked of. Okay. Fine. Good enough. I've had a few responses which I have recorded, and I will be tuberculosis. That's lovely. Semaglutide. Oh, semaglutide in type 2 diabetes. Okay. Management of rheumatoid arthritis, heart diseases, and diabetes treatment. Yeah, that again. So I will be writing down these next few things: heart diseases, diabetes, and somebody said rheumatoid arthritis. Okay. HHS. Okay, you're talking of the hyperosmolar hyperosmotic syndrome. Okay. So basically, you're talking of diabetic emergencies. Okay, fine. We can go for it. Pediatric dosage. Okay, pediatric dosage के लिए, okay, I'm not the best one to take it, but I will make sure that Mediversal is organizing a webinar on pediatric doses. I'll bring probably one of my pediatricians that we can have. Yes, can we reverse initial condition of diabetes due to stress without using medications through exercise and proper risk? That is exactly what I'm going to talk about in today's webinar. Dr. Prashant, if that is your name correctly, fluids management in emergency. Okay, yeah. Okay, we can talk about all of these things. Thank you to everyone who have poured in your suggestions, and I'll be sharing my screen now, and be wanting you all to join. Just give me a moment. Okay. So I'll be sharing my screen. Is my screen visible? Just give me a moment. Some issue. This. Oh no. Just give me a little moment. There is a little technical error. Just correct this.
Doctor?
Yeah, just give me a moment, sir. There's a little issue with my tab. I'm just
Sure.
correcting it in a
Sure,
minute.
sure.
Yeah. Vijay sir. Hello. Vijay sir. Excuse me.
Yes, doctor. Yes, doctor.
Vijay sir, I need a help of yours. The moment I am trying to share my screen,
Yeah.
I'm being moved away from the meeting. Is there some technical issue on your end? Can you please check that?
No.
Because see, I'm clicking on share screen
Hmm.
and
But the
I'm
camera will off. If yeah,
yeah,
it
I
is.
can understand. Yeah, I can understand that the camera will go off, but
Uh-huh.
just check. Is it visible now?
Yes, it is. The screen is visible.
Okay, the frame is visible, right?
Yeah.
Okay. Thank you. Okay, so let's begin this. Sorry for this brief delay that happened. There were some technical issues. So we are going to explore the reversibles, and by reversibles, I mean the modifiable risk factors. That's predominantly what we'll be talking about. And before I start, I always put an ode of gratitude to the teachers who have taught me. So that's something which is very common to my slides. And we begin our first slide with type 2 diabetes mellitus, risk factors and the screening recommendations. So I'll be zooming this for you, so it's easier for you to see. Yeah, I think this is good for everyone. Yeah. So the American Diabetes Association has come up with certain high risk factors that we need to screen. So what are the patients of high risk, who have a high risk of going into diabetes, who needs almost very frequent screening, almost 6 monthly screening is what we recommend. So the first one is physical inactivity. For someone who's exercising less than 3 times a week, I mean, I think a lot of people in Asia and especially India will fall into this category. High risk ethnicities, as I said, Asians have a predominant are a predominant race to be prevalent for diabetes mellitus. Hypertension, dyslipidemia, where HDL cholesterol less than 35 and or triglycerides are more than 250. This value is extremely important. So we know that HDL cholesterol is something which is cardioprotective. There's no more this concept of bad cholesterol and good cholesterol as we might have been studying in our elementary days, that LDL is a bad cholesterol, HDL is a good cholesterol, but there's nothing currently. There's no concept of a good cholesterol or a bad cholesterol, honestly. It is said that something that is produced in our body is produced for a reason, so we cannot really call it good or bad. So HDL cholesterol is a cardioprotective cholesterol, and that less than 35 or triglycerides more than 250 warrant screening for diabetes. Polycystic ovarian syndrome, because it comes under the entire compass of metabolic syndrome that we talk of, and insulin resistance. Clinical features of insulin resistance like acanthosis nigricans. I hope you know what acanthosis nigricans is. There's a dark colored hyperpigmented patch around your nape of the neck. Severe obesity, history of cardiovascular diseases. FDR is a first degree relative with the type 2 diabetes mellitus. And these people are at almost 2 to 3 times higher risk of developing diabetes mellitus. Okay. So these are the predominant high risk patients that we have whenever we talk of being very susceptible to screening for diabetes. There are some other risk factors which also the EDA talks of. Number one is abdominal obesity, old age, above 45, poor sleep quality, and stress. So stress is something that is extremely important for the predisposition to diabetes mellitus, and which is why over the years, as psychiatry has been emerging as a subject beyond a pagaloka doctor or psychopaths. That's what the society usually taboos it down to. As psychiatry and its scope and its dynamic nature has expanded over the last few years, and hopefully it will be doing even more in the next few years. We have concomitantly found so many molecules which are activated due to the stress due to stress, due to high cortisol levels. There is a disruption in the gut brain axis. The gut brain metabolism completely takes a toss off, and that can lead to a free radical mediated oxidative damage to the blood vessels. It can also lead to diseases like Alzheimer's. It can lead to cardiovascular abnormalities. It can lead to early MIs. It can lead to obstructive sleep apneas. So a number of comorbid conditions that diabetes brings if there is an associated stress with it or a poor sleep quality. Along with it is low socioeconomic status, as well as urbanization or westernization of diet. What do I mean by westernization of diet? See, even till 20, 25 years back, we never knew what McDonald's is. We never knew what KFC is. I mean, our parents' generations never knew what McDonald's and KFC is. So this paradigm shift from maybe the maximum that we would know about bahar ka khana is chili chicken, fried rice, or maybe chili paneer, fried rice, and all of these if you happen to be a vegetarian. So a shift from there to McDonald's and KFCs, that's what we call as the westernization of the diet. A diet that is high in fat, it's low in fiber, low in magnesium, uh, preservative added sugars like sodas. Smoking. Now, there's one thing that I want you to know. Transiently stopping smoking will increase the risk slightly. This looks to be a really paradoxical statement. I'm no way promoting smoking. I'm only trying to say this, that smoking is one of the highest risk factors that can be attributed. The point is, once you start to stop smoking transiently, there's a phase of weight loss, there's a phase of increased appetite, and maybe that is the reason why transient stoppage of smoking, due to its increased appetite and increased weight gain, will increase the risk of development of diabetes mellitus. Next comes alcohol, and in alcohol, we have that reduction in alcohol has a slightly increased risk compared to moderate alcohol, which is why the studies today are saying that do not completely stop alcohol, keep it in moderate amounts. And what do I mean by moderate amounts? It's a female who has at least one glass or one drink per day, and for a male, 2 drinks per day. This is not something that comes out as a sexual discrimination. Trust me, it's purely based on the metabolism of alcohol that happens in a female body, which is different from how a male body tolerates alcohol. Next comes environmental factors. Arsenic in drinking water. Trust me, arsenic in drinking water. You might be thinking, who drinks arsenic? Nobody drinks arsenic, but considering how polluted Indian rivers are becoming day by day, rivers which are worshipped as gods are the ones where we are throwing our trash. And if you have read some stories about the Yamuna or how polluted it is getting, how certain areas which are along the banks of the Uttaranchal, Uttarakhand, that's popularly called right now, you'll see how much of arsenic is present in those waters. Organophosphorus compounds, bisphenol A, that is used to make plastics, and epoxies. These are the materials which increase the risk of diabetes. So what are the screening recommendations? Anyone who's overweight, by overweight, I mean a BMI of more than 25 and more than 23 for Asians. So the next time that I'm going to talk of BMI, always subtract -2 for Asians. Okay? So if I say a BMI of 25, that's for the American population. When I talk of an Asian BMI, it's always going to be 2 lesser than that. Okay? Plus more than equal to 1 ADI high risk factors. Yani ki, these factors may say 8 factors, more than 1 factors are there, and the patient is overweight. You should always screen for diabetes. Next, age more than equal to 35, history of gestational diabetes mellitus, pre-diabetes, people living with HIV. HIV is associated with a lot of metabolic syndromes, a lot of comorbidities. So people living with HIVs. And if the results are normal, and what results am I talking of? I'm predominantly talking of HbA1c values. I'm talking of fasting sugar, postprandial sugar, and random sugar. That's usually what I'm talking of. Which maybe I always prefer the HbA1c value and the fasting value more because they tend to give me a more acute reflection. HbA1c, as we know, is a far better investigation. It's a very sensitive investigation. It shows you the average glucose control over the last 3 months. Okay, so a combination of these tests, if they are normal, then retesting every 3 yearly or earlier is what we usually give as the recommendation. Now, coming to glycemic targets. So one of the biggest changes that has happened in the NICE guidelines that I was talking of is earlier we used to have this concept that even labs today, I can tell you this, that laboratories, if you do a HbA1c test, and they will, in their interpretation, they'll write that 6 to 6.5 is a good control, is a very good control. 6.5 to 7 is a moderate control. 7 to 7.5 is a fair control. More than 7.5 is poor control. But now we have completely shifted from universal targets of HbA1c. When I talk of targets, I'm predominantly talking of A1c targets, HbA1c targets, right? So there are no more any strict universal targets. Rather, these targets have been individualized, which means it depends on patient to patient. It's like basically a custom module that you make, or maybe a custom dish or a thali that you order in the restaurant. Okay, so it's predominantly based on the customization. कि किस patient को क्या जरूरत है? What is my patient presenting with? What are the associated comorbids? What are the associated factors or risk factors that this patient has? And what is my requisite A1c target that I can set for him? For example, if my patient, so we have some patient or disease factors here, risks potentially associated with hypoglycemia and other serious effects, disease duration, life expectancy, important comorbids, and established vascular complications. Vascular complications mein kya aata hai? We have macrovascular and microvascular complications. We have retinopathy, we have neuropathy, we have vasculopathies, we have diabetes associated cardiovascular diseases. These all fall under the vascular complications. Now, suppose my patient is a patient who is having a lesser risk of hypoglycemia. Suppose he's on the low spectrum, and it's a relatively newly onset diabetes that has been diagnosed, and the life expectancy is something that is very long. Suppose this patient has presented to me, it's a 35-year-old patient. I think it's a relatively young patient who is recently diagnosed with diabetes, and risks of hypoglycemia or other drug side effects are very low. There's no other comorbids apart from diabetes, and there's no retinopathy, there's no neuropathy, there's no vasculopathy that's present in this patient. Then we should opt for a more stringent or a more strict control of HbA1c. Yani ki, for that patient, we should be considering an HbA1c of probably maybe 5.5 to 6, which means HbA1c for monitoring is no more based on lab parameters. It's based more on the individual parameters of the patient. Now, imagine a patient has come to you who is, say 85 years old. Okay? So the life expectancy is really short. There are comorbids in this patient, like suppose this patient has hypertension, this patient has CKD, okay, this patient has sepsis. He has recovered from sepsis maybe, or is a COPD patient. Okay, there are some vascular complications, like say he has peripheral arterial disease. Suppose this patient has been diagnosed with diabetes for the last say 20-30 years, and he is on insulin, all sulfonylureas. There's a potential risk of hypoglycemia. Then in these patients, there's a less strict control of HbA1c that we can advise. Maybe for that patient, I can set an HbA1c target of around say 8 to 8.5, something as high as that. Someone who falls in the middle, we can keep an A1C target of around 7. The in toto thing that I really wanted you to know is no more are glycemic targets universal, they are rather individualized. Okay? So now, what are the general goals in non-pregnant adults? So in general, in non-pregnant adults, what we would want is an A1C target of less than 7%. Less than 6% is what we say optimal in pregnancy. We will be keeping a pulse pressure of maybe of less than 180, and I mean sorry, postprandial of less than 180, and fasting blood glucose between 80 to 130. That's the target that we usually keep in a non-pregnant adult. And if we are using something which is called a CGM, I've talked of CGM in my earlier webinar on diabetes, that is continuous glucose monitoring. What is it? It's basically like an Apple Watch that you wear. Okay, the only difference is you wear it on your biceps, and there's a monitor that is attached to it. Whenever you take a meal, you get a graph from that machine. So it's called a CGM, or a continuous glucose monitor. You get a graph from that machine which tells you what is the time in range. TIR means time in range. Time in range का मतलब क्या है कि what is the percentage of the time in the day that your glucose levels were in the expected range that we want. यानी कि suppose I have given say I've given sulfonylurea to a patient, or say I've given metformin and SGLT2 inhibitor, like something like dapagliflozin to the patient, and I've said that I would want your fasting sugars to be in between 80 to 130, or postprandial to be less than 180. The CGM will actually tell me that throughout the day, what is the percentage of time that he or she has met this target. So our target is the time in range should be more than 70%. Time above range, yani ki the moments where the blood sugar was above the expected range, should be less than 25%, and time below range, which is also important, because not just are we supposed to treat hyperglycemia, we're also supposed to reduce the risk of hypoglycemia. Okay? And anytime there's a blood sugar of less than 54 milligram per dl, we know that's what we call as type 2 hypoglycemia. Anything less than 54 milligrams per dl is extremely fatal for any person, to be honest. Okay? So what I want to say is, if you're using a CGM, the targets are the time in range should be more than 70%, the time above range should be less than 25%, and the time below range should be less than 4%. In older adults, it will again be individualized based on the cognition levels, hypoglycemia risk, the risk of falls, falls, because anyone who gets hypoglycemia, and if it's an old patient, more likely to have a fall, more likely to develop CVAs, more likely to develop TIAs or hip fractures. So in these patients, basically, we will have to individualize the target. For example, someone with a low life expectancy, someone who's having an end-stage chronic illness like say CKD, someone who's having a moderate to severe cognition, say this person is around 80, 85 years old, there's a high risk of hypoglycemia, or this patient is persistently bedridden. In these patients, we can, as I said, we can keep a less stringent A1C goal. The fasting sugar can be ranged between 100 to 180. That can be our target. Our bedtime can also go between 100 to 180, so that there's less risk of hypoglycemia in the night. And the BP, we can be as lenient as less than 150 by 90. And there's no role of statins that has been established in this patient. Okay, because in the end of life care, the goal is to avoid symptomatic hyperglycemia and hypoglycemia only. We are not really looking at any other things. Imagine an 85-year-old, you cannot start this patient on statins right now. Okay. So the point entirely is, if it's a healthier person with say very few chronic illnesses, good cognition, no risk of hypoglycemia, no risk of falls and fractures, then you can set a very stringent A1C target. You can keep a fasting target of 80 to 130, a PP target of less than 180. BP can be restricted to around less than 140/90, and you can, if required, warrant the use of statins. I mean, I hope you all know this, that anyone who is above 35 years age and is having a BP over 140/90 and is diabetic, automatically becomes a candidate for starting off statin therapy. Okay? Okay, now let's talk of in details about the modifiable risk factors. So that's a slide. So the first thing is diet. So balanced diet is preferred rather than a diabetic diet. I mean, I've seen so many hospitals or physicians writing out a diabetic diet. There's nothing called a diabetic diet, to be honest. It's a balanced diet which is preferred. A diet which is in general high in dietary fibers. There's a moderation of alcohol and caffeine, elimination of sugary foods and soft drinks, mainly the sodas. And it is said that medical nutrition therapy, this is what we call as the MNT, medical nutrition therapy, alone can decrease HbA1c by 2%. Almost 2% reduction in HbA1c is possible. In fact, there are some simplified steps that we follow in MNT. That's what I've highlighted in this slide here as well. The first thing is consistency in day-to-day carb meal or snacks. So it's not about how much you're eating or how you're eating or what you're eating. It's about whether you're eating consistently. For example, today I cannot have 4 samosas and tomorrow at 7 p.m. I'm not eating anything. Then 2 days later, I'm again having, say, an Appy Fizz, not promoting or demoting any brand names. And maybe 5 days later, again, I am having, say, an aloo bhujia. This is not exactly the type of diet that we would want. So we are saying a consistency in day-to-day carb meal or snacks, especially in those who take insulin. That is extremely important because 4 samosas is going to spike up your insulin levels like over the roof. I mean, your blood sugar levels over the roof. So insulin has to do a lot of work to get that sugar levels down. The next day when you're not having samosa, and if your insulin doses are not adjusted, the same insulin dose can even lead to hypoglycemia. So that is exactly what I want to say, that there should be a consistency, there should be a uniformity in the day-to-day carb meal or snacks. The nutritional content, there is no ideal percentage of carbohydrates, proteins, and fats for all people. This is extremely important. The diet can be chosen by people themselves based on their personal preferences. Generally, we can prefer some plant-based diets that include minimally processed plant foods that improve the glycemic control. They're called low glycemic index foods, and they can also control or revert insulin resistance. What happens is these diets are rich in fiber and antioxidants, and these change the gut microbiome. As I said, gut microbiome is an extremely important factor that has been postulated with respect to chronic illnesses. You can search multiple papers on the gut microbiome axis or the gut brain axis, to be more precise, and you'll be finding how much relevance it has in today's world. And I'll not be surprised if today, with the advent of AI or with the advent of robotic technologies, we actually get to view the gut microbiota. Maybe in 10-15 years from now, maybe we can create an endoscope, like we can create a microscope inside a capsule, and that capsule will be taken by the patient, and maybe that capsule goes in through the GI wall and looks out for the microbiota that is present inside the GI tract. So I would not be surprised if something like this is coming up, or maybe someone from here takes up that challenge to maybe create something like that, because gut microbiome is something that has been extremely less studied. Yes, there have been theories that have been postulated, but then how much we have been able to link those postulates with a correlated hypothesis is something which is really the task of tomorrow. So we should be we are only going to see the massive amount of changes that will come out once the gut microbiota or the gut brain axis has been adequately studied. Coming back, lean proteins, by definition, lean proteins is what we encourage, and it's less than 10 gram of total fat and less than 4.5 gram of saturated fat per 100 gram. At least 2 servings per week of fish. Now, fish is something that increases omega-3 fatty acids intake. For people who do not like fish, like me, you can take walnuts. Walnuts are an excellent source of omega-3 fatty acids. Now, fats, substitute the monounsaturated fats, and by giving you should be changing your oils as frequently as possible. That is something which we keep on saying. Do not always cook in one oil. Change your oils as frequently as possible. Maybe one month you have a sunflower oil. The second oil you use in an olive oil. Sometimes you have it mustard oil. So it's said that as frequently as you change your oils, the better. Use low glycemic index foods like legumes, nuts, oatmeal, barley, corn, sweet potatoes, green vegetables. And one part that has been established is they can reduce prandial sugars. So there is a risk of hypoglycemia at times, but not really that severe. They can actually help in a good glycemic impact by reducing the sugar spikes, basically. Okay? So When I say reducing prandial sugars, I do not mean hypoglycemia, I mean the sugar spikes. Next, fiber. 25 grams per day of fiber for a male, 28 grams per day of fiber for a female, and sodium of less than 2.3 gram per day. So no Lays, no Kurkure, and none of those salted chips that you have. Chromium supplementation can be helpful in type 2 diabetes mellitus. Again, it's a summary of one of a trial that was seen. Chromium supplementation can be helpful in type 2 diabetes mellitus. It has been seen in trials, but it is not recommended routinely unless there is a deficiency. So unless there is any vitamin or mineral deficiency, we would usually not be going for any supplementation. The timing of meal and snacks, as I said, should be uniform. You should avoid erratic meal timings and you should adhere to consistent timings. Okay? Now, next. Okay. Now, coming to the weight loss. When I talk of weight loss, 5 to 10% weight loss has been shown to be extremely effective in prevention and treatment of type 2 diabetes mellitus. The goal, however, is to maintain an ideal body weight. So, anytime I am having at least a 5 to 10% weight loss, it is not just improving diabetes mellitus, it is also going to improve my insulin resistance. It is also going to improve the occurrence of diseases which falls under the spectrum of insulin resistance, like metabolic syndrome. For example, NASH, non-alcoholic steatohepatitis. For example, PCOD. So all of these things are something where we do recommend at least a 5 to 10% weight loss, and greater than 5 to 10% weight loss plus LSM. LSM is lifestyle management. Plus, it needs rigorous counseling. So what it has said is, see, weight loss is something that is very easier said than done. So I am telling a patient that, sir, you need to lose your weight by 10% is not actually the ideal way in which it should be done. So lifestyle management and weight loss requires rigorous counseling by nutritionists, by dietitians. More than equal to 16 sessions have been recommended over 6 months. I'm very sure that nobody in India is doing this, but trust me, weight loss is only possible whenever there's a motivation of weight loss, and that motivation has to not just come from the patient it also has to come from the family, it also has to come from the nutritionist or the doctor who's treating. Okay? So more than 16 sessions with a dietitian over 6 months, and if required, we can then go for pharmacotherapy for weight loss, like somebody was talking of semaglutide. That's Mounjaro. These days, it's very, very popular by the name of Mounjaro. Semaglutide, we can also go for bariatric surgeries. So what we do as pharmacotherapies or surgeries is something that is later, but initially, rigorous counseling, proper lifestyle management, modifications is something that we should be really considering if we need to talk of reversing type 2 diabetes, if at all. So, as I said, we have the 3 BMI categories, 25 to 26.9, and underneath every BMI category, there's a red colored BMI category, which is for Asians. As I said, for Indians, you should always subtract 2. So if the BMI is for Indians is between 23 to 24.9, you can go with lifestyle management and pharmacotherapy. If it is, if it is somewhere between 27 to 29.9, then you can go with, sorry, there's some mistake in this slide. I just forgot to correct it. It's just going to be the reverse. Someone with a BMI of 23 to 24.9, you will go for lifestyle management, and someone with a BMI of more than 25 is somewhere where you need to think of lifestyle management and pharmacotherapy. And if someone is having a BMI of more than 30 or a BMI of more than 27.5, who is an Indian, you can think of bariatric surgery as well. So when we talk of bariatric surgery procedures, there are some indications that we need to consider. A patient with a BMI of more than 40 without coexisting medical problems, in whom bariatric surgery would not be associated with excessive risk. Okay? So a patient of more than 40 BMI without coexisting medical problems, without hypertension, without hypothyroid, without COPD. Okay? Next, BMI of more than 35 and more than one severe obesity. I would actually request you to switch your microphones off. A patient with BMI more than 35 and more than equal to one severe obesity-related comorbidity may also be offered a bariatric procedure. When I say comorbidities, I include type 2 diabetes mellitus, hyperlipidemia, hypertension, OSA, obesity hypoventilation syndrome, the Pickwickian syndrome, NASH, pseudotumor cerebri, GERD, all of these diseases, or vascular diseases like venous stasis, DVT, all of this, or a patient with a BMI of 30 to 35 with diabetes or metabolic syndrome. That's the current. However, there's a limited evidence for people in this category. Someone with a BMI of 30 to 34.9 with diabetes, how much pediatric surgery is going to help them is something which has limited evidence in trials currently, but the first two ones are absolutely in line. Someone with a BMI of more than 40 without comorbids, someone with a BMI of more than 35, and at least more than one obesity-related comorbidities. So that is what the guidelines are saying. Now, we have a trial which is called the Look Ahead trial, and this is one of the famous trials that we had in diabetes. I'll just summarize the key findings of the trial. It said that so what is this trial? It was a large-scale, multi-centered, randomized control trial involving almost 5,145 overweight or obese individuals with type 2 DM. It spanned over 14 years, comparing an intensive lifestyle intervention. So lifestyle intervention was the major focus without pharmacotherapy. There is no mention of bariatric surgery. There is no mention of the pharmacotherapy. This was focused mainly on weight loss with lifestyle interventions versus the standard diabetes support and education. We found that in these two groups, the people with ILI, that is intensive lifestyle intervention, they lost an average of 8.6% body weight. That led to greater improvements in glycemic control, fitness, cardiovascular risk factors. However, one thing that is extremely common is, and I mean extremely important is, despite losing so much of body weight, despite leading to improvement in glycemic control, fitness, there was no significant difference in major cardiovascular events. I repeat, cardiovascular risk factors are reduced. Blood pressure reduces with weight reduction. Dyslipidemia reduces with weight reduction. But does the incidence of MI or heart failure or major cardiac events reduce with weight reduction? That is something that was a big no. In fact, this is one of the major reasons why this trial did not go further. I mean, it would have continued for several more years. But this one outcome, that is no significant difference in primary outcome of major cardiovascular events like MI, stroke, CVD was established. So ILI group had reduced risk of other complications like obesity associated complications were reduced, like, NASH was reduced, depression was reduced. There was a reduction in renal diseases, and there was an improvement in the mobility of the patient. There was a reduction in obesity, hypoventilation syndromes, obstructive sleep apneas. But cardiovascular events were not something that reduced. And of course, we had an improvement in compliance to medications, and also we had a decreased need for diabetes medications. 35% of ILI group achieved partial or complete remission of diabetes. So standing today, if someone says, is diabetes reversible? Yes, it is reversible only if it is diagnosed in the early stages and if lifestyle management and intensive lifestyle control has been initiated very early. Yes, it is reversible. But if not, which is usually the case with majority of the population, then reversing diabetes really becomes a challenge as of today. General principles of weight loss diets. So you'll have a lot of weight loss diets. You can search for Atkins diet. You can search for Mediterranean diet. There's a lot of other diets which are there. But the general principle is it has to be a balanced, healthy dietary approaches. For example, the DASH diet, the dietary approach to stop hypertension. This was one of the major prototype diets that was introduced, which actually targeted hypertension, but can also be used for other non-communicable diseases like cardiovascular diseases and diabetes. A low carbohydrate diet is usually chosen. Healthy choices for fat, monounsaturated and polyunsaturated fats, and proteins. Fish, nuts, legumes, and poultry should be encouraged with a reduction in red meat. Red meat like beef, like mutton. These are things which need to be reduced. If a low-fat diet is chosen, then the decrease in fat should be accompanied by the increase in healthy carbs. So the thing is very simple. It has to be a balanced diet. If your fat is low, then increase it with healthy carbohydrates. Healthy, I repeat, it's healthy carbohydrates, not chawal ki ek katori se 4 katori chawal kar do. Okay? So that is something which I want you to know. Even from the biochemistry perspective, I know this is going to get very elementary, but you should know this, that whatever carbohydrate we take, for example, suppose we are taking 100 grams of carbohydrate. I'm just saying it as a normal example. If I'm taking 100 gram of carbohydrate, at least 50 gram will be stored. And out of the 50 gram, 40 gram will be stored in my body as fat. So if you really need to reduce the fat of a body, you need to reduce the concomitant unhealthy carbohydrate. By unhealthy carbohydrate, I mean the processed foods, the refined foods, the sugary foods, the cold drinks, the sodas, and all of that. Okay? Most regain the lost weight after initial success, probably due to increased energy expenditure post weight loss and altered physiological signals or hormones. This is very, very important. There are so many people who start a weight loss journey, but within a few months they do achieve a bit of weight loss, quite a tic-tac amount of weight loss, but then they also start regaining the lost weight. And this is due to a decrease in leptin, peptide YY, CCK, and amylin. What is CCK? It's cholecystokinin. So leptin, peptide, YY peptides, these are neuropeptides, cholecystokinin, amylin. Because of these hormones and a reduction in leptin, they start again gaining the weight that they had lost. That's why I said maintaining weight loss is more important than just going for weight loss, because that is exactly where the role of a nutritionist, that's exactly where the role of a good motivator comes in, which is exactly why the number of sessions recommended has been how is that it has been in the trials. So maintaining weight loss is a challenge. It needs persistent adherence to diet and exercise. They may require pharmacological treatment or bariatric surgery, and it can result in diabetic remission in at least 30 to 63% of patients with type 2 diabetes mellitus. Yes, in fact, bariatric surgery has been shown to be one of the major reversals of diabetes. I can tell you this, during my time in AIG, which happens to be a center of excellence of gastro, I have seen this personally, that patients who had a weight of around 125 or 130 kilograms and their HbA1c was around 8.5 or 9%, I have literally found their HbA1c go down to 5.5 just with a bariatric surgery. Okay, so that's how useful bariatric surgery can be when it comes to reversal of diabetes. But then it has its own indications, and the indications are what we have definitely talked of. Coming to the penultimate slide, this is the recommendation for physical inactivity. More than equal to 150 minutes per week of moderate to vigorous intensity exercise, spread over at least 3 days per week, and no inactive period for 2 consecutive days. Yani ki Monday, Wednesday, Friday, Sunday. You can keep it this way, or Monday, Wednesday, Friday, Saturday. But do not keep Monday and then Thursday. So 2 days of inactive period is something that we do not recommend. At least 3 days per week with no inactive period for 2 weeks and 150 minutes per week of moderate to vigorous intensity exercise. More than equal to 75 minutes per week of vigorous intensity exercises may be enough for physically fit and younger individuals. What is the type of exercise? Aerobic exercises like endurance trainings or cardio, walking, bicycling, jogging, swimming, that increases cardiorespiratory fitness. Resistance exercises like muscle building, weightlifting, push-ups, they will increase muscle mass, muscle strength. And usually, if you're asked what is the best exercise, it's a mixture of the both. It's a combination of both aerobic and resistance exercises. So we have an intensity classification: low intensity exercises, moderate intensity exercises, and high intensity exercises. Here, we take a parameter that is known as the energy equivalent, or EE, and we have another parameter called the maximum heart rate. Can anyone in the chat box tell me how do you calculate the maximum heart rate of a person? Anyone in the chat box? I'll be waiting for your answers. Anyone who knows, how do we calculate the maximum heart rate? Suppose I am a 40-year-old man. What is my maximum heart rate? Yes, it is 220 minus age. Okay, so this has been said by Dr. Maheshwari, if I'm not wrong. So thank you, doctor. That's 220 minus age. So yes, correct. Your answers are correct. 220 minus age is the maximum heart rate. So when I'm talking of exercise, let me take you back to the slide. Yes. So when I'm talking of exercises, a low intensity exercises is where you reach 35 to 49% of the maximum heart rate achievable for the age. That's 220 minus age. Or energy equivalent is almost 1.1 to 2.9 METs, metabolic equivalent. It's basically the amount of oxygen that is produced per amount of carbon dioxide that you exhale. Okay? That's what we call as a MET. So a moderate intensity exercise is where you reach 50 to 69% of the maximum heart rate achievable for age. And a high intensity exercise is where you reach 70 to 85% of the maximum heart rate achievable for the age. If the patient is insulin dependent, then exercise should be a precautionary measure because you should always keep in mind the risk of hypoglycemia, and you should be treating the CV risk factors like hypertension, dyslipidemia with lifestyle management, pharmacotherapy as indicated. Final slide of the day, and we'll be wrapping up with this webinar today. This is the updated NICE guidelines. You can take a screenshot of this if you want, or you can go to the web. You can clearly type the NICE NG28 guidelines, diabetes management algorithm. They'll clearly give you this. So it says that number one, before you pick up a drug, first you try lifestyle, healthy living advice at every step. It's a shared decision making. Discuss the effects of the drug on HbA1c, weight, the cardiorenal outcomes, and the contraindications versus cost. If number two, let's move to flowchart in the number two. If there's a symptomatic hyperglycemia at any stage, consider insulin-based treatment or a sulfonylurea. Then review once the glucose is within target. Number one. So anytime I have a patient who is screened to be diabetes mellitus or is very pre-diabetic, I will have a counseling with this person about a lifestyle, about a healthy living. I will talk of what are the pharmacotherapy options we have. We will talk about its adverse effects on the kidney, on the heart, whether they're renal protective, whether they are cardioprotective, on the weight, whether they're weight neutral. We'll talk of the risk of hypoglycemias. We'll talk of the contraindications, side effects, and the cost. If at any point of time there's a symptomatic hypoglycemia, yani this patient is presenting to me at maybe in an emergency setup, say with diabetic ketoacidosis or anything, I will always look for insulin-based treatment. Now, number three, core default first-line drug. This is extremely important. In fact, this is the major change that has happened from the NICE guidelines of 2022. Earlier, the NICE guidelines of 2022 said, choose metformin as your baseline drug. Based on the patient's HbA1c targets or compliance, you will keep on adding whichever drug is required. So it was more based on the glucose targets. But now, since the HbA1c targets are no more universalized, they are no more strict, we are keeping a customizable HbA1c target. So what NICE has come up with is, it is saying that initial treatment for most adults, unlike the last release of 2022, is not just going to be metformin, but we will be adding, along with modified release metformin, we'll be adding an SGLT2 inhibitor like a dapagliflozin or a campagliflozin. In fact, dual therapy as the initial drug of choice of treatment is something that has been recommended by NICE in this year's edition of 2025-26. If metformin is not suitable, for example, you find that this patient is having a higher predisposition for lactic acidosis, maybe due to a genetic mutation, or metformin is not suitable for this patient because of diarrhea. Most patients cannot tolerate metformin because of a lot of diarrhea that happens in this patient. Lactic acidosis is one of the rarest complications. There's another complication with metformin, that is vitamin B12 deficiency, but it is very, very treatable. But diarrhea is one of the reasons why metformin cannot be taken by most people. Metformin, in cases when it cannot be given, SGLT2 inhibitor monotherapy is what you start with. And one more thing that I really want to clear up, even till quite a few weeks back, I heard this statement. I do not know why people say this, but metformin is not a weight reduction drug. Metformin does not reduce weight. Metformin does not reduce weight. It is a weight neutral drug. Please remember this. It does not reduce weight. It's a weight neutral drug. So the reason why it is given to PCOD patients is not to reduce weight, but it is to revert the symptoms of insulin resistance. So this is a very, very elementary and a basic thing that I wanted to correct. So that's number three for you. The choice of drug should be metformin plus a SGLT2 inhibitor, and it should be a modified release metformin. Yeah. Number four has 4A, 4B, 4C. There are three parts to it. If not at individualized glycemic target after initial therapy. So you've started the patient on metformin and an SGLT2 inhibitor, or you've started the patient on only SGLT2 inhibitors because this patient was not tolerating metformin. You will now start adding incretins if obesity is developing or the patient is on a higher BMI end. Consider a GLP-1 receptor agonist. Consider adding it within 3 months. If you need to achieve the target of HbA1c that you are looking at, consider adding a GLP-1 receptor agonist. If that is not suitable or not effective, you can then offer a DPP inhibitor. If DPP inhibitor is not present, if still uncontrolled, then you can add on either pioglitazone or you can add on sulfonylurea. Okay? So if and when and as and when the patient responds, you will go with sulfonylureas or pioglitazone. So what I want you to know is, you start the patient on metformin, you start the patient on SGLT2 inhibitors, and if the patient is having a higher BMI and your glycemic targets are not met, start adding incretins, that's a GLP-1 receptor agonist. If that is also not enough, start adding a DPP-4 inhibitor. If that is also not enough, start adding pioglitazone or consider pioglitazone or sulfonylurea. I'll always prefer pioglitazones because sulfonylurea currently has gone very much in the lower range. Unlike maybe drugs like gliclazide and glipizide, is still something that we can give due to some platelet, platelet anti-platelet action or anti-thrombotic action that they have. But sulfonylureas are really something which is not really in the front line as much as the incretins that we have today. If your drug, if your glycemic targets are well met, then if it's met in the first 3 months, then you can consider adding a GLP-1 receptor agonist. If required, if you feel that you need to counter obesity, the patient is maintaining a good A1C target, but you need to, treat obesity, you need to reduce the BMI of this patient, you can then go with a GLP-1 receptor agonist. And as I said, so in any patient with type 2 diabetes who is having a predisposition to go into CKD, you will try to avoid metformin if the EGFR is less than 30. So anytime with an EGFR less than 30, avoid metformin. Anytime with diarrhea which is not responding to treatment, or a diarrhea which is severe enough to cause enough problems in the compliance of the patient, do not give metformin. But in case you're not giving metformin, always start off with an SGLT2 inhibitor. The best thing is always metformin with an SGLT2 inhibitor, and the next step is to go on with incretins. If not, then DPP-4 inhibitors, GLP-1 receptor agonists. If not, then DPP-4 inhibitors. If not DPP-4 inhibitors, finally you can either choose between sulfonylurea or pioglitazone. Just remember one thing, pioglitazone is something that you will be avoiding in a patient with family history of urinary bladder carcinoma, and you will be considering the fact that it can cause a slight weight gain in some patients. That is due to the water edema or the water weight that increases in these patients. So in a patient of obesity, be a little judicious when you give pioglitazone. Otherwise, it's one of the finest drugs, in fact, to be given. The benefit of SGLT2 inhibitors is not just based on the cardioprotective action. It is also based on the fact that it is also a renoprotective drug. And when I say this, just give me a moment. When I say this, it's also to say this that SGLT2 inhibitors like predominantly dapagliflozin, empagliflozin, and canagliflozin, these three have been shown to effectively be the drug of choice in patients with diabetes and heart failure with preserved ejection fraction, that is the HFpEF. So in these patients, these are extremely cardioprotective drugs. In fact, even if there is a diabetic nephropathy that develops in a patient, the first line drugs that we try are the ARBs, that's the telmisartan or the losartan type of drugs. And along with it, we also try this patient on SGLT2 inhibitors like DAPA, EMPA, and CANA, because they reduce significantly the incidence and the chances of proteinuria. The only consideration that we need to have with these drugs, mainly the SGLT2 inhibitors, is got to be the presence of urinary tract infections and candidiasis. So if it's an old female who is having a lot of other comorbids, has a high risk of, is not a well-controlled diabetic, and is also having recurrent UTIs, you prefer not giving SGLT2 inhibitors. But otherwise, these drugs are extremely safe for the renal support in cases of diabetic nephropathy. It in fact reduces the progression to nephropathy, and it has also been shown to be of great benefit in patients of diabetes mellitus when it comes to the cardioprotective roles, or in patients of HFpEF, that is heart failure with a preserved ejection fraction. So that brings me an end to the seminar, to the webinar. And we have discussed about the guidelines. I know it was predominantly a guideline-based webinar discussion. Nothing from my end to explain, but I would still take up any doubts that you have pertinent to this webinar. For any doubts about management of diabetes, I will not take up any question today, because I will really want you to go back to that webinar, which is present on YouTube. You can easily go in the Mediversal's website on YouTube. You'll find the discussion about the drugs, the insulin, the dosage, and everything that has been given there. Yes, I'm not detailed about the insulin doses, because that would take a separate session altogether. But I've talked of the insulin preparations, I've talked of the oral hypoglycemic drugs, their contraindications, their indications, their benefits, their risks, and everything. So I will take up any other question based on whatever we talked today. PDF of that session. You want this PDF or you want that PDF? I mean, उस session का PDF. Wait, let me see. How can we get these slides so that we can revise? Okay. So Vijay sir, are you there?
Dr. Yes, I'm here.
Yeah. So I think we can. I mean, they are saying if they can get the PDF for this to revise. So yes, you can. I think the team will connect with you. Nahi to, I am also saying this. You can simply go to Google, type out NICE guidelines, NG28, NICE, NICE, NG28 guidelines for 2025-26 for management of diabetes mellitus. You will get the entire booklet. Number one. Number two is you can look out for the Look Ahead trial. That's the name of the trial that I wrote there. Look Ahead. And next is I talked of the ADA, American Diabetes Association screening guidelines. So that's exactly the summary that I've put in here. If you want, you can get the PDF. I think the team will connect to you accordingly, or else you can look out on the internet for these 3 topics that I talked about. Insulin dose calculation, I have not taken in insulin dose calculation, my dear, but I have taken the session on preparations and formulations of insulin. Dose calculation of insulin is again something that we will be taking up at some other point of time. I've talked of insulin preparations, I've talked of its efficacies, I've talked of the time onset, I've talked of CGMs there, I've talked of how to interpret a CGM report. I have talked about oral diabetes medications, its contraindications, its side effects, everything has been discussed there.
Thank you, doctor.
Okay, somebody has written 28-year male with 10% HbA1c. Okay, fasting is 285. Okay. Now I have a problem with your question. So I appreciate you asking me this question, Dr. Ashish. But see, when you are telling me this, what is the proper management? It is extremely difficult. First of all, in this webinar, when you ask me a question, this personalized, that how do I manage this patient? One thing I can tell you from this perspective is you need to monitor the cardiovascular health of this patient. You need to go for a routine echo and an ECG. Okay? Number one, you need to screen the fundus for retinopathy. You need to do a urine ACR. You need to do an urine REME to check for proteinuria, if any. Apart from that, if you have a family history of stroke or TIA, you can then be looking for markers like D-dimer, PT-INR to check for the coagulopathy or the vascular diseases, if any. Because this patient is having such a high HbA1c, I would request you to check if this patient has varicose veins, or if at all, you can do a bilateral venous Doppler, lower limb Doppler for the patient. Nothing more. You can be testing a 1 gram monofilament test for checking out neuropathy, if any. Irregular sleep and sedentary lifestyle. Yeah. So first thing is, of course, lifestyle management. You go with pharmacotherapy, and based on whatever you have written, we can also consider bariatric surgery, but then that is something that will be opinionated only by the bariatric person. Isse zyada I cannot say here because, as I said, this is not a clinic. We can only stick to the areas that we can talk of. But yes, a cardio analysis, a nephro analysis is something that we definitely would want. This patient is also having high triglycerides. It's almost 461. Check out the USG abdomen. Check what is the grade of fatty liver. Check if there's a fibrosis. You can do a fibro scan in this patient. If it's just a fatty liver or whether it's fibrosis, you have to treat accordingly. Statins definitely have to be introduced based on the weight and the compliance of the patients.
Great. Doctors, I have also pasted the certification link in the chat box.
Yes.
Please do click on it and submit the form to get your certificates to your straight to your email ID. If not inbox, please do check on spam box to get your certificate. Sorry, doctor, you can continue. Sorry.
No issues. I just okay. Somebody said how to treat vitamin B12 deficiency on metformin medication. See, vitamin B12 is something that you take in diet. So you can take diet. You can check your vitamin B12 levels. If you're a vegetarian, then of course you will have a more tendency to develop vitamin B12 deficiency because vitamin B12 only comes from the meat sources. So in that case, you will need to probably take supplements of vitamin B12. Apart from that, not required. Is it necessary to take metformin in early initial diabetic stages? Again, initial matlab, you cannot be a 50-year-old male and saying that I am in initial diabetic stage because I have just been diagnosed with diabetes. No, you being diagnosed at 50 doesn't mean that you had diabetes from 50. Diabetes is a long-standing disease. There's a lot of time that elapses from the onset of diabetes to the time from where you are screened. Mano, you are 50 today, you've been diagnosed with diabetes today, but maybe the process had started in you when you were 30. So basically, you have lived with diabetes for 20 years. Okay. In that case, you definitely need metformin. If you're a 30-year-old male diagnosed with recent onset diabetes, you are not having a sedentary lifestyle, you're motivated enough to try and integrate, intensive lifestyle management, start off with it. If it's not working in 3 months, you should be thinking of starting pharmacotherapy. Again, only if you do not have other comorbids. ऐसा नहीं कि आप में hypertension भी है, dyslipidemia भी है, you are a recent onset diabetic and you just want to start off without pharmacotherapy. That's not how it works. It's only a combination of the factors. If you are not having any other comorbids apart from diabetes and you're 30 years old or 35 years old, you can try an integrated lifestyle, intensive lifestyle management for maybe 3 months, 4 months. Keep checking your HbA1c levels, and based on that, you can then follow up with your clinician as to, if required, you can take the medicine or not. Okay? Any further questions?
Any questions, doctor? Please do drop in chat box. Dr. Navonil will be able to answer your questions. Now, let me also drop the link again to get your certificates.
Details about LADA. Details about LADA has been talked of in my earlier webinar. You can again go to LADA there. I've answered, as of now, whatever questions have been there, I've answered all of that. So, if there's any more questions,
I think, doctor, we can call it a day.
absolutely.
Thank you so much, doctor. On behalf of all the doctors, I would. Okay, we have got one more question.
Patient is already vitamin B12 deficient and patient taking metformin. Metformin can cause vitamin. Yeah, metformin can cause vitamin B12 deficiency. As I said, if the vitamin B12 levels are low, you can. Okay, so if your vitamin B12 levels are low or normal, whatever it is, and if you're a young patient, if you have a history of cardiovascular events in your family, I will tell you to check methylmalonyl CoA levels, MMA, that's what we call. The blood levels of MMA can be checked. And based on that, we can see if MMA is also less. Usually what happens is vitamin B12 is normal, but MMA is less. Okay? Vitamin B12 can be normal or near normal lab ranges, but MMA can be less. And that is something that can be problematic later. But in case of your patient that you talked of, that this patient is on metformin, this patient has vitamin B12 deficiency, you can check the vitamin B12 levels, supplement it, and based on that, you can be treating this patient based on what levels are there currently. If it's a vegetarian, you can give vitamin B12 injections. If it's a non-vegetarian, food has enough vitamin B12 to supplement it. Maybe you might need some oral supplements till the time that food catches up with it. Vitamin B12 is a very, very nice vitamin. It stays stored in your liver for at least 2 to 3 years. So if you're having a low vitamin B12 levels, it really means that you have had a good amount of undernutrition for quite a long period of time. Vitamin B12 does not, come very acutely. It's not easy to get a vitamin B12 deficiency. Not that easy. Old webinar you will be finding in YouTube.
YouTube, yeah, live section. In
Live
our
sections.
YouTube, please go to our YouTube channel. In the live section, you can stream all our old
Yes,
webinars there.
yeah.
Do we have a chance to talk to you, sir, now? Yes, Dr. Prashant, if you want me, you can talk.
Yeah, sure.
1 second, I'll allow you. Dr. Prashant, you can unmute yourself now and you can talk.
Hello, sir. Very good evening, Dr. Prashant. I have a question for you. a person with 42 years of age, and because of a stress factor that related to family issue, he was detected as diabetes. Actually,
Okay.
his fasting is around 243. 3 months back, his sugar levels are around 193, and
Okay.
and in these conditions, because of only stress factor, because his father was expired, and his mother was in medical ICU conditions, so he was stressed so much. And can we and his HbA1c is like 11.2, like that.
Mm. Okay.
So he may be from past 6 7 months he was under continuous stress.
Mm.
And can we reverse this without proper diet and medication, as you mentioned in the chart? As per the chart, if he starts today, how will be the result, without using any medicine?
Okay. So I think you were the one who posted the question, right, Dr.
Yeah, yeah,
Prashant?
yeah, 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 yeah. I
Yeah.
want
So
to know that. That's why I'm asking you
I
directly.
already answered your question. I'll be again saying it. So the first
Yeah.
thing is, if a patient is having an HbA1c of 11%, it cannot just be due to stress. Okay. Stress can
Okay.
contribute to diabetes, but stress cannot lead to diabetes. That is what I'm saying. Stress is an aggravating factor to diabetes. But when someone has
Okay.
an HbA1c control as bad as 11%, that too at the age of 42, it clearly means that this person's uh, insulin resistance is extremely, extremely high. Now,
Okay.
with the BMI that you said, I think his BMI is more than 30, so it means he's overweight as well. There's enough, there's depression in this patient, there's stress levels. Yes, we can take care of the associated factors of stress. We can provide psychological counseling, we can provide medications if required for the mental health condition. But all of that will only maybe help him to sleep better, or maybe get some motivation for doing exercises or live an intensive lifestyle. You cannot be starting off with lifestyle management for a patient which who has a HbA1c of 11%, because that 11% HbA1c means this patient has been having a fairly poor glucose control for a very, very long time. And a high HbA1c as high as 11% does predispose this patient to be at a risk of nephropathy or retinopathy or cardiovascular events at any point of time. So you cannot be just keeping this patient on just lifestyle management. Lifestyle management will be the backbone, but there has to be pharmacotherapy that also needs to be introduced. Okay? You can also consider bariatric surgery because this patient is overweight. You can consider bariatric surgery at some point of time if you really want to reverse. Since you're talking of reversal, bariatric surgery is the only thing that can probably reverse to a certain extent, not really otherwise.
And he has his family history too, sir. Like his father and mother was diabetic, actually.
Yeah. So
Uh,
again, so whenever there's a family history, again, so that's what I'm saying, that only stress cannot lead to an HbA1c of 11%. Okay.
okay.
HbA1c is something that is calculated, that is going to give me a glucose control for around 3 months. आज अगर आपने टेस्ट किया है, it will give me a report of how your glucose control was there for the last 3 months. Stress can lead to diabetes. It can lead to an aggravation in diabetes, but it cannot lead to diabetes per se with an HbA1c that bad.
That's what I. And doctor has just like see the metformin for twice, morning and even before breakfast, and night after before dinner.
Correct.
Twice they have suggested, and that person is asking me can I do, because
Now
being
you
a
have
doctor,
to
actually
start
I
off with
cannot.
medication. You have to start off with
Yeah,
medications. There is no doubt about that. But then how much dosage of the medications, how long to continue, and everything will depend upon how his glucose control is, how is
yeah, and
HbA1c.
after 3 months only we can rectify that,
Yes,
right?
absolutely,
Yeah.
absolutely. Yeah, yeah.
Thank you so much, sir. Thank
Thank
you
you,
so much
thank
for
you, thank
valuable
you.
suggestion.
Yeah,
Thank you, Prashant.
thank
Thanks
you.
for connecting. Um, we have also again dropped the certificate link. Please do click on the form link and submit the form. I think, yeah. Thank you, doctor. Thank you so much. Behalf of on all the doctors here, I would extend my heartfelt thanks for you to connecting this time and shedding the light on this particular topic. Also, including very latest information which uh, shows how dedicated you are to teaching community. Thank you so much, and
Thank you,
thank you,
thank you so
doctors,
much.
for joining this evening. We have a few more webinars planned for the month. Please do visit our social media channels. I'll also drop the links for the social media so that you can find us easily. Do follow us on social media channels to stay updated on all our upcoming webinars. We are planning more webinars in the month of March. We'll announce the calendar as soon as possible. But now we have 2 more webinars left. Please do attend, and happy learning.